trying to reach that American dream, and they're not given a chance because they're brought to this place where nobody cares.
And is there an understood financial incentive to diagnose COVID?
Yeah, of course. So in the hospital that I'm in right now, it's all COVID at this point. Every single floor is COVID, and they need it that way, obviously, for a reason, in my opinion. But a person cannot come to the floor unless they have a COVID diagnosis.
Is the reason, did they not want to cross-contaminate? Would that be the legitimate reason why you would create an all-COVID floor?
Here's why I will say no to that, is because they're admitting people for, quote, COVID rule out. So this guy was probably admitted COVID rule out, tested him, they saw that it came back negative. They probably already did something where they needed to now call him COVID, in the hopes that if they're putting him on a COVID floor and there's nurses going room to room to room, he will get it, and then they'll be backed when he does pass that he did have COVID.
Now, I mean, that's quite a charge. I mean, what makes you think they really want them to get COVID? Because
money. Money. I think it's at least $29,000 per patient, and then you have to think you are also charging supplies and more supplies and more supplies. That's just like a bonus money.
But but the residents aren't getting that, right? I mean, why?
Oh, that's the thing. And I actually I've went at it with a lot of residents already, and they're order followers. So there was a resident, and I have this on tape. I taped it because it was just so disgusting to me. A 37-year-old, which is my age, was not a DNR. He has a full code. His family in depth discussed with the doctors that they want us to do everything they can to save him. He came in talking. He was very terrified. He was just like, totally alert, knew what was going on, and they convinced him to be on a vent. Now he's dead. But the doctor said when I got into shift that if he codes, that we are not to resuscitate or try to save him. And we flipped.
This is important. I just asked them if we can put a DNR order, and they said no. That's up to the attending.
Okay, so we're going to code him.
That's what I said, and they said no, we're not. I said yes, we are. Yeah. We're obligated to. So then
you got to say something though, like it's our license. Unfortunately, you guys got to put in an order, just something.
That's what I said. Yeah. I said I'm obligated.
Yeah.
What did she say?
So then she's like, the higher up said. I said I don't care what they said.
What higher up? God? We don't have a God here making decisions.
I said I don't care what they said.
So we're supposed to. He's not DNR, but we're treating it as DNR.
Basically.
Does his family know?
His family knows the situation. I think they called them and they told them. They were trying to do a school attending consent for DNR.
Okay.
All day he spent like in the 80s saturating. It was this one on the forehead didn't work. It was this one worked, and it came back. When I changed it, I was like, oh shoot, it's 90.
Yeah.
So they started playing around with the
Oh shoot, it's 90.
Because he's still on pressure.
He changed the pulse ox
You put him on AC,
from
drop.
his head to his finger, and
Well,
he's
yeah,
like,
no,
oh,
I
it's
last
90.
week. I had to put a sign up last week. Don't touch my.
He's fine.
Nothing.
So.
Yeah.
So what was that?
So that was, we were just getting on shift because we're starting the night shift at 7. And that was the nurse from the day shift saying pretty much we shouldn't code him if he's going to code. And then I turned my glasses on.
Why are we being told not to code him, essentially? That's what he said. I mean, because I'm going to tell you right now, if he bottoms out, I'm jumping on his chest. Period. Point blank. It's going to happen.
Okay.
Because until that status is changed in the computer, that's what I'm obligated to do under my nursing license.
Right. I mean,
because you guys aren't going to back me up and protect me.
Well, Elmhurst does have a policy given, like a COVID policy, given the scarcity of dialysis and blood.
It can be a chem code, it can be whatever.
That it's not, there's not a, it's a difference. Normally the standard is whatever the family
Right.
says, like we just do. So
Right.
if they would say code him for 5 years, like we just do that
Right.
until they die. It's a little bit different now because of the new policy in place with
Right.
Dr. put in place, which is that you don't need full family like you can just tell someone that it's medically futile and that we're not
Right.
willing to just pour blood and resources into something that would be impossible to get back.
Right.
But look, it's brutal. He's 37. I mean, it's brutal.
Well,
So
they
they
tried.
said, well, our higher ups have agreed and our attendings agree that this is futile care at this point. He is not going to make it. I said, he doesn't have an epi drip going. He doesn't have anything to sustain going. And I said, and who decided this? And I said, can you put a comfort care order in then? No, we can't do that. Can you put a DNR order in? No, we can't do that. I said, so what's our plan?
Do we have
Well,
to modify?
she goes, well, he's dying. And I'm like, I understand that, but there needs to be an order indicating that either I'm doing compressions or I'm not doing compressions.
Well, I can say that we can all be in agreement that we will do it. I will definitely.
Yeah.
Because I'm going to jump on him.
Yeah.
So will I. I'll go right with you. I don't care. That's what we're here for. I'm not playing like these
until
stupid
they
games.
change his status that he is a DNR, and they can do it through physician consent if they've talked to the family.
Yeah.
But until they change it, and I see it, he's a full code to me.
We know when we're close. We'll pull the code card up and be ready. You know, we're ready. I had the epi ready. That's one of the first things we do. And she wouldn't let me give it. So this was that woman. And the entire time, and this was over his body, his alive body. And we're arguing and she's laughing. She was smirking. And how this man died was the nurses arguing with the doctors over him as he was dying, and she's smirking the entire time. It was probably one of the worst experiences in my entire life. But all I can think about is that at least he knows that we were fighting for him when he died. You know. But this was my conversation after what happened, and the guy I told you about earlier that had pulled his tube out, he was up at that point. Like, he was on the same floor. He was the one that they wanted to sedate. So at that point he was doing better where he could walk. This doctor had put a diaper on him and told him to poop in his pants. So after the code, I went to go check on him, and he goes, I have poop in my pants. I'm like, why do you have poop in your pants? And he said that because the doctor told him that he has to do that, and I just lost it. It was her.
This is wrong. It is straight up it is wrong. And I am 37 years old. I have been in a hospital since I've been 16. Military hospitals that well.
What aspect of it was wrong to you? I agree that there were parts of it that were wrong too. So.
Calling a patient a DNR when there's no order for it, and telling us, like straight up telling us, you're not doing anything. That's wrong. If that was my brother or my father or anybody, I would be furious. And I guarantee you, if I called his family right now and told them what happened, they would be furious too.
I flipped. We were all crying. There's a lot of nurses that know that this is wrong, but they're afraid to like say anything publicly.
She said, when I was talking to her, she said, we're not always given the orders. It comes from the top down. And I was thinking, that's the exact problem with everything. Where's it coming from? What's the purpose? Are you guys really trying to kill everybody like everybody thinks?
Within our unit, it was a big fight, and ultimately the kid died with us over his body arguing about this.
The girl's over there.
Yeah.
And the doctor will just write it up that we
Yeah, I don't trust him though, because I don't know him.
I'm sorry. I'm not doing that.
There's a doctor that came upstairs that I had worked with prior. He was working in the ED and heard what happened. He came into the room with me and told me that what I did was good. And then, so there are good doctors in here. I guess the word traveled after this.
You mentioned earlier that this is a common occurrence where people come in able to speak and they just have low oxygen levels and they're put on a vent. So what's going on there?
I don't know. I honestly, I have no idea how they're assuming everybody is just the same. There's no individuality anymore. These residents, I think a lot of them are just stone cold. You know, there's no emotion, and they don't view people as people anymore. And it's really sad. Like I came a little bit later, you know, after the big rush, but there were still a lot of people coming in. And a lot of us were just in shock. Within the first couple days, you could see exactly what was going on.
My bigger problem with this whole scenario is when they intubate people who don't need it.
Yeah.
And it looks very clear to me that they're just pushing it.
You almost feel like you are literally living in the Twilight Zone. And you feel like you're the only sane one in a bunch of insane people. And it's scary because these are the people that others are trusting to take care of them. And they're really doing the opposite. I'm to the point where I'm afraid that I'm going to start thinking that this is normal. I don't want to ever get to that point because they think that. Like the people I work with that are local nurses and doctors don't see anything wrong with this.
Really? I mean, they don't.
No.
Do they see? Was it just like kind of a hard past few months? Is it or?
This has been like this, and from what I hear, like I mean, there are good nurses that work there too. Like I have made good friends with a lot of the nurses that do work there. There's good people, but they're outnumbered.
So what happens? People come in like this 37-year-old, and what was he complaining of, or what was going on?
Respiratory distress. He didn't have COVID either. He did not have COVID.
And how do we know that?
I took care of him. I have the same type of results from his chart as I do my other patient.
It was like the day before intubation, he was fine on the rebreather.
And then they intubated, and then he got a pneumo, and then they put in a PEP tube, and then it's been shit.
And now he's 37 years old and dead.
Because that's what I'm seeing. Like all these negative tests, and they're putting them on these vents. Hopeful that they'll get it. They're being put on these COVID floors. It's murder. It straight up is. It is setting these people up for failure based on money.
But Medicaid is who pays out, or who's paying this bonus of $29,000?
I believe it's Medicaid, Medicare. It's government money, but I don't know exactly where it's coming from. But I know that it is. But I know the orders are coming from the above, someone above, and everybody says that it's someone higher up. I'm like, good, call them. Like during that DNR when they're telling us, or the full code when they're telling us not to, do CPR. I'm like, all right, call your higher ups then. Let's talk about. And they wouldn't, because they're all scared. Everybody's scared. And everybody's scared to stick up for themselves. And I've called a lot of doctors unethical to their face, and they deserve it.
I'm a nurse. I'm an advocate for my patients. And
to the flip side of it, but I totally agree.
But no. Just wait.
If there's a DNR.
You were laughing and you thought it was funny. You were like smirking. You're being really rude to all of us. And I thought that was really.
I'm not being rude in that.
It was really, yeah, you are. It was very disrespectful. Okay. And I don't think that you're going to be a very good doctor.
Okay, I understand. Thank you.
You're welcome. I hope you learned something from this.
Was this the dentist, or or these are residents you're talking to?
This one was a fellow. She was a CCU fellow. Cardiac. She was a cardiac fellow.
What killed him? Did the vent kill him?
Yeah. Oh, yes. They're so sedated. He had probably 8 or 9 drips. It's all sedation. It's all sedation and paralytics. So you are asleep. It is essentially like you're under, you're in surgery, when they put you under like that, for a good month straight. There's no way you can recover from something like that. You'll be brain dead if you do.
So can you list some of the drugs that they're put on the drips?
Yeah, there's propofol, fentanyl, Nimbex.